Thanks for that intro. So kind. I work for Island Health in the BC Academic Detailing Service, which you may have heard referenced in the insomnia talk. Thank you for the shout out there. I'd like to start by acknowledging that I live and work on the territory of the Comox First Nation. I'm so happy to be an employee of Island Health, and Island Health receives money from the Ministry of Health so that I can work in academic detailing, for which I'm grateful. So why are we talking about bupropion? You may remember we talked about it a couple of years ago. So bupropion is the second most commonly prescribed antidepressant in British Columbia, with 102,000 people receiving it in a recent one-year period. You may recognize it by its brand name, Wellbutrin. And so in Canada, it's available as two different formulations. We have Wellbutrin sustained release and Wellbutrin extended release. At the conference in 2020, we addressed this common comment. Tom had seen this in a recent consult. We will switch her from bupropion SR to XL 300 milligrams, which is the newer superior version. And what we talked about was that we could say that the XL, the newer version, is bioequivalent to the SR version when dosed at 300 milligrams per day. But the evidence for superiority in clinical outcomes is lacking. There aren't cost implications now to switching people. They're both available generically. It's just we couldn't say to someone, you will get a superior response if we switch you to the XL. We also talked about the fact that bupropion is amphetamine-like in its pharmacology, and adverse events are dose-related: agitation, insomnia, tremor, tinnitus, and seizures. We didn't talk enough, I don't think, about toxicity and overdose, and that's when Vincent and I started chatting. So what I'm going to do, though, just briefly, because he is the main event, is to talk about some other questions that have come up surrounding why would we choose bupropion, and that pertains to off-label reasons for its use, like anxiety, ADHD, and sexual dysfunction. And I'm going to address some of this using a network meta-analysis, and I just want to mention what they are in brief, because they're an increasingly common evidence synthesis method, and absolutely necessary in my view when we're looking at an issue that has more than 3 medications. And you'll see they're being used by Canada's Drug and Health Technology Agency, Cochrane Systematic Reviews, NICE in the UK, and ARC in the US. So they're inescapable. And they can provide comparative estimates of drugs, even though some of them haven't been compared directly. So just as an example, if you were to endeavor to try and understand the relative efficacy of 21 antidepressants, you'd get pretty exhausted pulling 21 different systematic reviews, all using different methods. So a network meta-analysis would use, hopefully, a rigorous and transparent method and kind of give us an overview of the relative efficacy and safety. And so this did happen for antidepressants for major depressive disorder, just a massive body of evidence, over 500 trials. And just Cole's notes, what they found for bupropion, say compared to our other 2 commonly prescribed antidepressants in BC, they couldn't differentiate between them in terms of antidepressant efficacy. So nothing really, if we go back to our top 3 antidepressants, nothing here to differentiate them in terms of their efficacy for major depressive disorder. This network meta-analysis in the Lancet didn't get into specific adverse events, but there was a 2021 review of bupropion by Cait. They did look at efficacy and actually found 5 systematic reviews showing no difference in efficacy for major depressive disorder with bupropion compared to other antidepressants. But they did find, and this is often indicated as a reason for choosing bupropion when I talk to clinicians, that it will cause less sexual dysfunction than SSRIs. So obviously a very important difference in safety. It's a little bit difficult, I find, to translate this because sexual dysfunction is defined and reported inconsistently in the trials. So it makes it a little bit difficult to translate for patients. So for example, which aspect of sexual dysfunction? Is it, less of an impact on desire, arousal, or orgasm? It would be really hard to explicitly explain this, I think. So this is where things fall apart for bupropion, is when, we might say, oh, we're choosing it because someone has co-occurring anxiety or ADHD. We're choosing it and we're adding it on to an SSRI, hoping it will treat sexual dysfunction. And so what I like about network meta-analyses is they provide a visual representation of the available evidence for each medication. So I'll show you for generalized anxiety disorder and then ADHD. And just bear with me for a moment. I know this is dizzying, but you're going to see these visual representations of evidence more and more. So this is a network meta-analysis of medications for generalized anxiety disorder. And I've circled our drug of interest, bupropion. And you can see that each drug has a size of circle, and that's proportional to the number of randomized participants, And then each drug has a different width of line, and that's proportional to the number of trials. And for example, a drug, if it were compared to placebo, would have a direct line to placebo. So if we look at bupropion, for example, we can see for generalized anxiety disorder, it was never really established as being efficacious in comparison to placebo. And it was a comparator drug in a trial with escitalopram. It's connected here and to fluoxetine. But I just kind of get a big look to see, okay, what is the representation of my drug of interest compared to many of the other drugs that we commonly use. And if the reviewer, the systematic review authors are kind, they'll, at the bottom of this graph, give you a table that tells you the numbers of trials and participants. So for bupropion, for generalized anxiety disorder, you can see that it's just 2 RCTs and 41 participants. So tiny body of evidence. And I'm just comparing it here to the body of evidence for bupropion for major depressive disorder. And then I've just pulled out for you here, okay, so our other 2 most commonly prescribed antidepressants that do have official indications for anxiety disorder, venlafaxine and escitalopram, have a much bigger body of evidence. So that's just as a starting point how I use these network meta-analyses. And then they did show that bupropion, kind of by using indirect methods, is possibly more effective than placebo for generalized anxiety disorder, but the efficacy estimate, as you can imagine, with just 41 participants, was really very imprecise, and it included both, it could have a clinically important effect or a clinically unimportant effect. So that's why I say things kind of fall apart for bupropion as, a reason to prescribe it for generalized anxiety disorder. Similar for ADHD, this is a network meta-analysis, and you can see the evidence here for amphetamines and methylphenidate in adults compared to bupropion. Small body of evidence and kind of a similar conclusion that the efficacy estimate was very imprecise, meaning both a clinically important and a clinically unimportant effect. Okay, this is where things fall apart even more. So bupropion as a treatment for sexual dysfunction. So we've established bupropion has a lower risk of causing sexual dysfunction than SSRIs, but sometimes you'll see a suggestion that it will treat SSRI-associated sexual dysfunction. So this is from Up to Date, and if you go to that chapter, it will say for females with low libido, we suggest augmentation with bupropion, so adding bupropion to the SSRI at relatively high doses. And then if you read further on, it says a meta-analysis of 3 trials found that bupropion improved sexual dysfunction, but the largest trial was retracted. I've never actually seen that before in an Up to Date chapter, but a bit of a red flag, right? And so I put the author of the retracted trial, I put his name into retractionwatch.com. And a few months ago, it was 19 journal article retractions, and now it's 27. And he, in fact, was, from this meta-analysis of 3 trials, the author of 2 of them. So as I say, things really fall apart. If we suggest to people, we're going to add on bupropion and it will treat your SSRI-associated sexual dysfunction, I would say that that's not proven. So why do we think and hope so many things for bupropion? In 2012, the drug company settled a $3 billion fraud suit, and it included that they had participated in the off-label marketing of bupropion, including for things like anxiety, ADHD, and as a treatment for sexual dysfunction. Also, it was being promoted as a drug you could easily add on to other antidepressants. And I just wanted to point out the Cait review in 2021 concluded that adding bupropion to someone's current antidepressant treatment, if they were considered not responding enough to that first treatment, didn't improve outcomes any more than just switching them to bupropion. So something to consider. Before adding bupropion, maybe switching might be preferable to minimize medication burden and polypharmacy. The last thing I just wanted to mention, because this will tie into Vincent's discussion, is just a quick revisit of whether we should be pursuing the maximum daily dose of bupropion of 300 milligrams per day. So should that be a target? So again, I mentioned we have 2 formulations in Canada, the SR and the XL. The maximum approved dose is 300 milligrams per day, which is given as a divided dose, 150 SR twice a day if you're using the SR version. And if it's the XL version, 300 milligrams once a day. And the only semi-objective dose response analysis I can find of bupropion comes from the SR drug approval. They looked at 3 RCTs, which included dosing it from 100 to 400 milligrams per day, and they found no relationship between dose and antidepressant effect. So something for my pharmacy colleagues to keep in mind. I know I would often see that someone was on bupropion 150 SR once a day, and I would think they're being undertreated. And I would suggest that we should increase it to twice a day. But one of the 3 trials in the FDA review actually compared that exact scenario, giving the SR once a day versus twice a day, and there was no difference in antidepressant efficacy. May not be a surprise. I just added this after watching Tom's talk. The half-life of bupropion is 20 hours. I just want to acknowledge one thing we're really missing for bupropion is sort of a more complex dose response analysis. We had one published for SSRIs, venlafaxine, and mirtazapine in 2019, where they took all of the published and unpublished trials. And I'm just going to show you an example of why this is important. I've only learned over the past few years that Health Canada will approve drugs with a dosage range. Here I'm using mirtazapine as an example. The dose range is 15 to 45 milligrams per day, but yet if you read further in the monograph, it says a relationship between antidepressant response and mirtazapine has not been established. As a pharmacist, I would have thought, oh, I need to potentially keep increasing the dose up to 45 milligrams to get the maximum effect. But this dose response review found, and it's interesting for many of the drugs, but for mirtazapine, that efficacy increased up to 30 milligrams per day and then actually decreased. So just keep in mind when you see these dosage ranges to try and look a little bit further and actually see if there is a relationship between increasing the dose and improving the response. And with each topic we do in academic detailing, we find examples of where this relationship has not been proven. So just 5 things I think I know about bupropion. It's the 2nd most commonly prescribed antidepressant in BC, so we should understand its clinical toxicology, and Dr. Wong will help us with that. It potentially causes less sexual dysfunction than SSRIs, but it's lacking any credible evidence that it would treat sexual dysfunction. I'm much less confident that it is an efficacious medication for anxiety and ADHD compared to other first-line medications for those indications. The best available evidence does not indicate that increasing the dose to 300 milligrams per day will increase response. And always keep in mind that adverse events are dose-related. So I'm going to stop there and pass it over to Vincent, which is the main event, as I mentioned.
All right. Thank you, Cait, and thanks, Aaron, for the introduction earlier. I think we share this event versus being the main event. But good morning, everyone. My name is Vincent Wong, and I'm a family doctor, and I work as a physician liaison with the BC Drug and Poison Information Center, which I'll abbreviate as DPIC in this presentation. I do want to be clear that I don't represent myself as a toxicologist or a poison specialist, and that my training is in family medicine. But my work does revolve around communicating between the various specialty colleagues in DPIC, as well as their consultations to other physicians and health professionals, as I'm doing today. My disclosure statements are listed on the screen, and instead of reading them out, I just want to highlight that I have no specific financial relationships with commercial for-profit entities, and that I won't be mentioning any specific brand names of medications in this presentation. And I do receive remuneration for my work with the various organizations and institutions as listed. So why are we talking about bupropion today, particularly in the context of drug poisonings and toxicities? We know that bupropion has a variable toxic dose, meaning the dose in which it can cause toxic effects in patients can be variable. It's also a drug that has a narrow therapeutic window, which means that the doses between which it exerts a beneficial therapeutic effect and the dose that it can create an undesired toxic effect is very small. So practically, this means that even at therapeutic doses or doses that we intend, or an accidental double dose, which is not uncommon when one forgets that they've taken a medication, adverse effects and harms are possible. For bupropion, this is mainly in the form of seizures as the main hallmark of side effects. And we do see a dose response for the risk of seizures. And there's about a 0.1% risk at 300 milligrams. We talked about that dose earlier, or Cait did, which is the therapeutic dose here in Canada. And in the States, which also approves a 450 milligram dose, that's up to 0.4%. Obviously, it's higher in bigger overdoses. What this means is that even a patient who might have inadvertently taken a double dose, such as forgetting they've taken a dose on that day already, would require hospital-based cardiac monitoring for the various side effects and adverse events it can cause. There's other toxicities, particularly in the cardiac and central nervous systems, that can be significant as well. So I'm about to present to you some of the data that we've collected at DPIC, which compares the numbers of calls we get for bupropion as compared to other common antidepressants, such as escitalopram and venlafaxine, particularly as they relate to cases of unintentional error and cases which result in a serious adverse outcome, as well as being admitted to critical or intensive care. Of course, the data would have its limitations, and obviously this is only limited to data that we receive at DPIC, which largely calls from British Columbia and Yukon, and would exclude anything that obviously is not reported to us. It is administrative data collected based on the drug, so it doesn't differentiate based on the various indications for which the drugs are prescribed. And in the interest of time, I've only selected the relevant and significant points for presentation today. So just to start, I want to show you the number of calls we get for each of these three drugs in the past 5 years. This includes all sorts of calls, from inquiries about experienced side effects to consultations and major overdoses, but just gives you a rough idea of how many we get for each of these three medications. In general, they've been trending up, but that's not the focus, more so just to show the point that they're fairly similar in the number of calls we get between the three drugs. In the upcoming slides, I'll present the number of cases based on these numbers, both as an absolute number of cases as well as a percentage. So the first set of information I want to present is the cases of unintentional error. We see that the number of cases of unintentional errors, and obviously when people call, it obviously reaches an internal threshold to their own definition to call. But in this case, we see that when people do call on an intentional case of error, it is higher for bupropion than the other two drugs. An intentional error here could refer to when patients report they've been having an effect due to an unintentional nature, such as accidentally having taken additional pills or doses, experiencing a side effect due to an intentional error, perhaps on behalf of someone else, such as in the dispensing or prescribing process. This obviously excludes intentional overdoses, which I can share are quite similar across the 3 medications. We don't really have the data to break down the individual source of error, but we can take this to mean that a greater percentage of people hit their personal threshold, which is usually an adverse event that they feel to need to call regardless of the source of error. And now I want to present to you the cases of serious adverse outcomes based on the 3 drugs. There are some technical terms in which the national poison data is coded, but basically here I'm referring to outcomes that are life-threatening or cause significant residual disability. In the case of bupropion, examples could include repeated seizures, ventricular tachycardia with hypotension, or cardiovascular instability, just to give some examples. Generally, these occur more so with larger overdoses, but these numbers reflect both intentional and unintentional causes. Bupropion, both as a number and a percentage here, result in a higher rate of these serious adverse outcomes when compared to escitalopram and venlafaxine. And if that's not compelling enough, I'll move to the next slide, which shows the number of cases in which patients are admitted to critical or intensive care. Again, we see here that bupropion takes the lead here, where when it's usually in a case of misuse, results in a higher case of admission to higher levels of care, such as critical or intensive care. Now, a critical eye might ask, why are these numbers higher than the last slide when there are serious adverse outcomes? And while I don't have an absolute answer, it's very possible that when patients are initially admitted, if there is a significant concern, they can be admitted to a higher level of care than they need based on their level of perceived disability at the time. In any case, the situation is similar across the 3 drugs, where the numbers on this slide is higher than the one in the past. So I've shown all this data, and what really is my point? The point is obviously isn't to memorize or recall any of these specific numbers, but the point here is just to show that bupropion might not be as safe as we think. We heard Cait present earlier about how bupropion's evidence for effectiveness might lag behind some of its comparators, and certainly in my own training, I was often, at least in my training, the traditional teaching was, know 1 or 2 drugs and be familiar with it and move on, and bupropion was often a common alternative for many of the other therapeutic options. So here I do want to present that bupropion is a drug with some safety concerns, particularly when it's misused. It's a narrow therapeutic window drug, which makes it more susceptible to adverse events, even in the best of times. And like I mentioned earlier, even a double dose could require hospital observation, whereas for many other drugs, it might be fine to monitor and observe at home. It does have a higher association with serious or major adverse events and admission to critical care. And I think back that in my training, bupropion was often presented as a wonderful alternative when other first-line agents didn't work well. And my goal is to highlight that some of these caveats do exist that might not be well known. From a safety perspective, this of course isn't a suggestion to not use bupropion. I'm sure many in the room have had successful experiences, but just to be mindful of its use, particularly in patients who are at risk or have a tendency to end up in an overdose situation. This can be intentional, such as recurrent or active suicidal ideation, but also can be unintentional in those who have a tendency to be forgetful or take double doses. This is particularly true when it's available in a larger supply, whether it's supplied by us that way or in those who might stockpile. So some of us family docs might be conventionally or usually prescribing a 90-day supply because of drug reimbursement rules. And we often do that for many chronic medications. And in some patients, this might be viewed in the same way. While no overdose is good, in patients who have a higher risk, it might be useful to limit or reduce some of these quantities through frequent dispensing programs or blister packs. And so that even if an overdose occurs, the risk of harm is reduced. So that's the end of my presentation, and be open to questions either for me or for Cait.
Great. Thanks, Vincent and Cait. The wonderful presentation. I'm not sure how you crammed so much information into 25 minutes, but impressive job. We have a few minutes to go through some questions. So, Cait and Vincent, the first question, do your calls for bupropion exposure differ in terms of circumstances, especially suicidal attempts?
Maybe I can take that one because I think it had the word calls in it. Not really. So I had a one-liner, but I didn't want to present too much data on numbers that look very similar. I think when we're looking at intentional overdoses, if I can paraphrase that way, the numbers across the three medications were quite similar. And I think my interpretation would be it's probably the natural course of their condition, regardless of what medication they're on. And so it's simply a means of access. And my focus on this presentation was more, well, when people do or do end up in an overdose situation, what do those outcomes look like? But in terms of just the intent of overdosing, I haven't seen any significant difference in our data locally.
Okay, thank you. Another question, could we expect similar numbers when using bupropion for smoking cessation, or were the data collected regardless of indication? And I think that relates to the serious outcome data that you showed, Vincent.
Yeah, I might have been speaking too fast, so I apologize. It is administrative data, so it's just simply based on the number of calls received. So it could have been for any of the indications, whether approved or not. We just don't have that information to be able to break them down into which which indication they were prescribed for.
Okay, thank you. This could be for either of you. Does bupropion increase suicide risk more than other antidepressants?
I don't know, Vincent, if you want to take that. I haven't seen sort of a textured enough differentiation between antidepressants on suicide risk. I don't know if anyone else here in the audience has, but I've seen nothing to suggest it either has a higher risk or lower risk.
Okay, thanks, Cait. Any comments on safety in the elderly population?
No, I've looked into trying to find evidence for bupropion in older adults. And what's kind of interesting about the drug company is they actually report, you can do a search on their website for their clinical trials. And I found a few in older adults where the abstract suggests the drug was not helpful for major depressive disorder. But those trials did not end up getting published. So I haven't seen a systematic review that has the skills to look at antidepressants in older adults while also looking for unpublished trials. That would be brilliant.
Okay, thanks.
Maybe
Cait.
one comment.
Sure.
Comment I'll add with respect to the elderly is should they have dementia or something that allows them to forget their medications. A lot of the situations I talked about with, just missing a dose, forgetting they've taken their meds already could apply. So I think there's that risk just from a logistical perspective. I don't have any specific data based on age that I have prepared today, but perhaps in a later situation I can look those up. Thank you.
Okay, thanks. There's so many good questions. I apologize. We won't be able to get through to all of them. But I will pick one, and it relates to the use, substance abuse issues related to bupropion and crushing and snorting. And do you have any comments on that, or any calls that you received related to that?
From my perspective, because in prep for this presentation, I've really been looking at the data from a more administrative standpoint. I haven't read every single report, obviously, but I'm certain that a good number of those calls would be from situations resulting from the abuse situations described.
Okay, thanks. Cait, actually, one more question. I lied. This one's for you. Do you know the smoking cessation literature and any information about dose response for that indication?
No, that's a great question. I just focused on the most common reasons, but Aaron, I think that's such a good question. If we could answer that and post it on the website or however you're planning, because I'd love to know that too. I also, can I answer a question? Dr. Chin said, as a psychiatrist, I'm surprised that bupropion is number 2. It isn't for me personally. Can you break down practices based on specialty? And we couldn't do that. No, we just asked for numbers of patients who have received the drug. But in my experience working with people in primary care, where there's sort of a hope, it will treat more than one thing at the same time, which obviously we all aim to reduce polypharmacy, but just sometimes it's not grounded in evidence.
Okay, thank you both so much for a wonderful presentation. Again, I'm sure no one was expecting so much information and so practical. So thank you very much.